Neonatal Quality Collaborative. Thank you for joining us today. Good morning to those of you on the West Coast and Central Time there, and good afternoon to our Eastern Time zone here that we have in Ohio, all the way through the East Coast there. Let's go ahead and go to the next slide, please. Today's presenters are leaders from across Ohio who will be sharing their expertise with all of us. Dr. Mike Marcotte is from the Tri-Health Health System, Good Samaritan Hospital specifically, and he's also the OPQC OB faculty lead. Ryan Everett comes to us from the Ohio Hospital Association. Dr. Jim Greenberg is from representing today Cradle Cincinnati, the Ohio Collaborative to Prevent Infant Mortality, and the Perinatal Institute at Cincinnati Children's Hospital. And lastly, we have Kay Smith, who is coming to us from ProMedica Toledo in Toledo, Ohio. We can go to the next slide, please. So at this point, I do feel like we're all quickly becoming Zoom experts, right? We will stop and ask that all attendees please be certain that they have used their participant code. If you have signed in without it, if you could go ahead and hit pound and then the participant code and then pound again, we'll be able to connect you with your email to your audio there. If you have joined without using it, again, that is how you're able to sign in and put those together. Additionally, we are recording this call. It will be posted on our website along with the slides. We are not enabling the video cam for this, just with a large number of attendees today. And we can go to the next slide. We will group mute the lines. The lines are group muted, but we want this call to be interactive. Please do utilize the chat box throughout this call. We'd love for you to add your questions, your comments, your reflections. I see that we're seeing some questions already coming in, and really we're hoping to address many of them that came through registration and through the chat box today. And we can go to the next slide. So in keeping with the foundation of a collaborative, our goals today include sharing the practicalities of implementing these strategies now, and then also to discuss what people are doing, where guidance doesn't exist, where it's unclear what others are doing in this situation. I want to share a quick story with everyone. On a planning call with Dr. Greenberg, and I hope he'll be okay with me sharing this, I mentioned my concern to him, just that after this, our quote unquote normal was going to be drastically different, and just some of my fear that we wouldn't really be getting back to normal. And I think that his response speaks to what we are trying to accomplish today. And that is, he said he agreed that it would be very different, but what was paramount, that it would be, what have we learned? And today I'm hoping that today with that thought, to have this all teach, all learn approach, and hopeful to move forward with that. We have over 360 registrants for this webinar, and our focus topic and scenarios today are regarding surge planning. Again, like I mentioned, the slide deck and the recording of this webinar will be posted on the website. There are also many resources there that we have compiled from our past webinars and our past presenters, and that is updated regularly. And then lastly, the case scenarios that have been posted and that we discuss are from individual institution responses and not OPQC recommendations. We can go to the next slide, and I'd like to turn this over to my colleague, Dr. Mike Marcotte, to take us through the global, national, and state perspective. Dr. Marcotte? You might need to hit *6. Are you there, Mike?
I am here. Can you hear me, Susan?
I can hear you now. Yes, thank you.
Okay. Thank you, Susan, and thanks to all of our project management team for their incredible work to keep us going on a week-to-week basis to be able to provide this forum for discussion. So just from a perspective point of view, I wanted to point out this is our third week of running these webinars on Friday, and we're actually starting to see some changes as we look at the numbers. Still an incredible number of people have been diagnosed with COVID-19, both around the world and in the United States. And we're starting to see more consequences of these patients in terms of the number of deaths that we've seen. But I wanted to point out one thing about this slide just compared to the others, especially in the United States. In the first week that we were looking at this data, we nearly had a fourfold increase from 1 week to the next. But this past week, we've only seen about a doubling of the number of cases. So I think this is an example, and definitely in Ohio, we've seen this of a flattening of the curve, which we're going to speak more about today from the Ohio perspective. So I really appreciate all of our speakers and look forward to hearing a very robust and interesting discussion around surge planning. So I'll take the next slide and introduce a poll. We wanted to talk about whether or not you and your system have changed your surge plan as we've heard about the flattening of the curve and whether that's impacted things. So take a minute to answer this question.
And Tracy, we'll rely on you to go ahead and give us feedback as to, here we go. All right.
So it looks like it's about, more commonly, people have not changed their surge plan, but a quarter of us have made changes, and about 50% are either not sure or don't have surge plans because of your role. So that'll be important as we look to the next speaker. So we'll close this and move on. And I wanted to introduce Ryan Everett. He's a colleague of ours who is the Director of Community and Public Health Programs with the Ohio Hospital Association. And if you're from Ohio, you know that the Ohio Hospital Association has had a key role working with the Ohio Department of Health in helping us to understand, manage, get data, and help make plans as Ohio tries to respond to this pandemic. So Ryan, thank you for taking time out of your really busy schedule to be with us today.
Thank you, Mike. Can everybody hear me?
Yes, we can hear you.
Wonderful. Awesome. Well, good afternoon, everyone. I'd like to thank the Ohio Perinatal Quality Collaborative team for the invitation and opportunity to be with you today. I also want to send my sincere appreciation to all of you on the call on behalf of myself and the Ohio Hospital Association. I know this may sound cheesy, but I mean it sincerely. I'll steal Dr. Acton's now famous line where she stated that not all heroes wear capes. We know that the heroes right now are in white coats, they're in scrubs. If you're working remotely, they might be your favorite pair of sweatpants. But regardless, we're grateful for all of your efforts, and we're thinking about you and your teams every day during this crisis. So I wanted to provide a brief overview of what OHA has been doing to support the statewide efforts to address the COVID-19 pandemic. Next slide, please. So some quick background. We kind of stepped into this space when we were reached out directly by the governor's office to see how OHA could assist in this statewide work and in the statewide response. And in a very short period of time for a relatively small staff, we have about a third of our staff fully redeployed in the COVID-19 response right now. One of the first asks we received from the governor was to assemble a executive committee. You've probably heard him reference this multiple times on his press conferences and otherwise, but we assembled CEOs, clinical leads, CMOs, and others from across the state and created an advisory team that the governor has been working with closely since the start of this pandemic. We had daily calls with the team from the governor's office, and oftentimes they join our calls as well. So we had a CEO call just this week, and Dr. Acton chimed in at one point in time, and Governor DeWine chimed in at another point in time. So we're working very closely with their team We can't express enough our gratitude to Governor DeWine, Dr. Acton, and their team for their leadership during this pandemic. I think everybody's aware of the great work that they've been doing. Wanted to note that we've put together some strategic work groups as we do this work. We've put together some work groups related to surgery. So you may be aware we stopped doing elective surgeries here across the state in an effort to preserve PPE. So we assembled a work group for that. We have a work group working on nursing home issues. We have work groups that work with the different regions across the state. We also have some ad hoc groups we put together around things like crisis standards of care, allocation of scarce resources, and otherwise. We do know hospitals are taking a huge financial hit right now, so our health economics team is also working hard to determine various ways to alleviate that issue. And I'm not a big finance person, so I won't go into those details, but I did want to note, we did apply for a federal ASPR grant that you may have heard was going to be allocated directly to hospital associations for hospitals. And we applied for that. It was a $1.7 million grant. We should know today if we received that, and if we do, we'll share information to the hospitals here in Ohio on how that's going to be distributed. I wanted to talk through the regional planning. I know on the first slide I had a map, and you'll see it kind of throughout. Wanted to quickly make sure folks were aware. I think as somebody who was originally from Northeast Ohio, I used to always think of Northeast Ohio as Akron, Canton, and Cleveland. But the state divides up our emergency preparedness into 8 regions. The first region being the Toledo area, the second region being the Cleveland area, third region being the greater Dayton area, fourth region being Columbus, the fifth region being Akron, Canton, or what they call Northeast Central, then Cincinnati, and then there's 2 regions, one being in the central southern part of Ohio, and then southeastern Ohio. So we have our 8 regions, and you may have heard the governor discuss previously in a call, I think earlier this week, or press conference earlier this week, that they're actually creating zones now. So many of these regions are now going to be working together to address this issue here in Ohio. So the regions of Toledo, Cleveland, Akron, and Canton are working together. The regions of Columbus and then South and Southeast Ohio are now working together, and then Dayton and Cincinnati are partnering together as this work. And I think when we think about, to Susan's point earlier, what are things that we're learning from this, it's just truly amazing how hospitals are coming together and working together to address this and work on this together. We're seeing hospitals that are usually seen as competitors in regions and very fierce competitors in regions, all getting on calls together and working together. Everybody realizes what a big issue this is, and we've discussed with our leadership, it's going to create an interesting dynamic once we move past this crisis, how our hospitals are now have worked together and have these new relationships in addressing these crises. And I think the last thing I wanted to touch on in my quick overview piece was, you may have heard there was an order on April 1st around testing and ramping up testing here in Ohio. We're still seeing a lot of shortages in that. We know that folks don't have enough swabs in different places. Some folks don't have enough testing medium. Some folks don't have the resources to do that. We hear backlogs in the private labs. So our team's still working on that. We're trying to make sure we can ramp up testing. We know we're still under testing here in Ohio. So just wanted to note that that's something that we are working on. Next slide, please. So as we think about today's topic around surge planning, I first wanted to address one of the new things that OHA has been doing to help support the statewide work. This has involved creating a data collection mechanism from hospitals to help drive local, regional, and statewide planning. Next slide, please. So this is a data collection tool that we put together. It's a once a day data submission. It's 8:30 every morning. All of our hospitals in the state submit to this. We have over 200 hospitals reporting daily. They report things around bed counts, ventilators, ECMO units, status of various PPE and staffing levels, as well as we recently added suspected COVID counts, positive patients in the ICU and ventilators. And so we're using these for two reasons. One is obviously for planning purposes at the local, regional, statewide level, but this also is helping as we think about the models that we'll talk about as we go through this. These number of hospitalized patients are now being fed into the models that the state's using. So having accurate data here is actually really helping and driving what's going on at the state and how we create these models, how we plan on the models. So you'll notice, I know I got some questions about planning specific to maternity and OB care. You'll notice we don't have OB beds in here right now. That wasn't something that was asked from the governor's office for us to consider in this. But we do know that that's being considered locally, and a lot of folks have talked about how, and I think some of our later presenters will talk about how they've considered where you do your OB care. Do you use some of those beds for your COVID patients? Do you move your OB care to other sites? And some of those things. So we're aware of that, but that's not something that we've been tasked to do as we think about these beds right now for this crisis. Next slide, please. And so to make sure folks can leverage that data that we're collecting, we've created an interactive dashboard that's directly live feed from that data collection tool. So a caveat I'll make for this in the future slides, all of this data is old. So if you're an Ohio hospital, don't make any assumptions off of what you see on these slides. I just more wanted to show that we have these dashboards that feed out of that data, so you can see bed capacity, ventilator capacity, and you can see those things by region. So regions can plan off of this data and see how everybody's faring. Next slide, please. And this is just another tab of that dashboard that allows for state and regional planners to see the needs of resources. So you'll see, we've changed this tab a little bit, so it's actually related to days on hand of PPE. So it'll tell you days of hand of gowns and things like that for various hospitals. So this helps our statewide planners as they get new resources identify where the needs are for different types of PPE. Next slide. And so now I want to turn quickly to what's been discussed at the state and local levels most recently, and that's the surge planning and modeling. Next slide. So you may recognize this slide if you tune in to the daily 2 p.m. press conferences with Governor DeWine and his leadership team. ODH and OHA have partnered with experts at The Ohio State University to create models around when the surge will come to Ohio. So as you can see by the orange peak, our statewide efforts and social distancing have kept us from hitting that originally projected peak, which is a model based on no mitigation efforts in Ohio. So obviously we have many mitigation efforts. So that obviously isn't what happened. You can see there's a barely visible light blue line, which reflects the latest data from OHU released this week, showing a much lower curve. So obviously it goes without saying that this is incredible to see how our statewide efforts to flatten the curve seem to be working. It's absolutely crucial to remember though, and I'm sure I don't need to tell you on the phone this, but it doesn't mean that our work's over. These new models assume that we're able to hold the course in Ohio. If Ohioans see this as a victory and go back to, try to go back to business as usual, it obviously immediately could turn back into a large spike. So models are models, and as we get new data and as things change in Ohio, it'll change the models. So we're working with the team at OSU to regularly update these models. So we should have a new model in the coming days, and we'll see how things look. Next slide, please. So I wanted to also quickly share that OHA has leveraged the OSU data into one of our dashboards. So again, it's actually a visual of the previously modeled data. So again, don't try to look at these, the data that's on here. It's really more to show the visual itself. But this is to support local efforts. You can see what we've done with this is leverage when we know how many beds hospitals are telling us that they have. The data from OSU is telling us how many hospitalizations for COVID patients are expected to happen at any given time. So we're helping hospitals see in your region you have X number of beds, in your region you're expected to have X number of COVID patients, or you're expected to need X number of ventilators. And so all of that data is within those dashboards. And so the intention is for those to be able to be used as folks are doing their surge planning to get a sense of where the needs might be as far as beds or vents or otherwise. You can look at this by the region, you can look at this by the county. The data isn't, that right now they haven't done it at the hospital level because it becomes a lot harder to do that at the hospital level because of where your intake of patients might come from. So right now we're just looking at county and regions. And I do want to, as I've shown all these screenshots, I do want to say that the hospitals in Ohio do have access to these dashboards. Right now, we've provided them to your hospital CEOs and CMOs, as well as your hospital preparedness, your emergency hospital preparedness folks. So if you think these would be valuable to you to use as you're doing your surge planning related to maternity care, reach out to those folks at your team, and they should be able to provide you access to that. If they can't, you can reach out to me, and I can be of assistance there. And then next slide, please. So lastly, I did want to share with you this graphic that came from a recent state situation report. This shows how regions are preparing for the surge and planning for alternative care sites. So I know that the new data has already influenced this. As we saw earlier, some folks said they've already made changes based on the new data. We've seen that the regions are doing the same thing. So I know this has changed. I was on phone calls yesterday where folks have already downgraded the number of beds they're planning for their alternative care sites. All of this data is fed up to the State Emergency Operations Center, which is merged with data from OHA and ODH to allow the state to make data-driven decisions as we plan for the surge. So you'll see where those are kind of scattered across the state. Again, many of them have already moved down the number of beds that they anticipate needing in those regions. So I'll note lastly that even as we consider the latest models, which seem to indicate good news, it's important to not let up. As ODH leadership continued to share yesterday, we must continue to hope for the best and prepare for the worst. So even if, as the models are currently showing, we may have sufficient beds and vents and those kinds of things in most of our regions, we still face shortages of PPE. Again, our decision to stop doing elective surgeries was intended to help make sure we have enough PPE. And so a lot of hospitals are asking, can we start doing surgeries again? Well, no, not until we have a sufficient influx of PPE to make sure that we can keep our healthcare providers safe. We know this is, even if the surge is small, it's still a high risk time for providers, and that PPE is so essential in keeping our healthcare providers safe. And so we still have our work cut out for us. So I think with that, I tried to fly through a lot real quick. I think with that, I'll turn things back over to the OPQC team to see if there's any questions. I think we'll do those at the end, but I think that's my last slide.
Thanks so much, Ryan. That was very helpful. We could go to the next slide, and Ryan does have his contact information here, and that also will be shared at the end of the call. There are several questions in the chat box, and I again encourage you to type in your thoughts and questions and reflections there. Ryan, we do have a question that came up. Are we tracking obstetrical specific morbidity or mortality with COVID? And I'm not certain if you would know the answer to that, but thought I would throw that out there.
So at this point in time, I'm not aware of that. So a lot of this data does, other than what we directly collect as OHA, a lot of the other data actually flows through the local health departments. And so the hospitals report to the local health departments who report to ODH. And as somebody who's not deeply involved in that process, I don't know if that's included in that. We have an administrative data set that works off of coded data. I know there's some new ICD-10 codes around COVID, but that data won't flow in for a long time from now. So it's possible that we might be able to look into that a little bit, but I'm not aware if that's being done on a kind of a very active, timely basis.
All right, thank you so much. And then there are numerous questions in the chat box that I'm hopeful you'll be able to reply to some of those. Thank you. I'm going to go ahead and go to the next slide now, and it's my pleasure to introduce Dr. Jim Greenberg. He is the director of the Division of Neonatology at Cincinnati Children's Hospital Medical Center. He's also the co-director of the Perinatal Institute at that hospital. And if that's not enough, he's also the co-director of the Ohio Collaborative to Prevent Infant Mortality, or OXIM. We're delighted he's able to share a regional perspective and a neonatal perspective here today. Dr. Greenberg, I'll turn it over to you.
Great, thanks so much. And you can hear me okay?
Yes, loud and clear, thank you.
Wonderful. So just to echo Ryan, I really appreciate the organizational talents of the OPQC team, and appreciate the invitation and the opportunity to speak. And again, to thank all of you for everything that you're doing. We can't overemphasize that enough at these interesting times. And as Susan pointed out, I really do hope that we learn from this. This is a tough time, and it's easy to get down and frustrated and exhausted. And one of the things that keeps me going is looking forward to all that we're learning. So if I could have the next slide. I'm going to share with you in the next few minutes how we're thinking about the surge from a neonatal standpoint. And I will finish up with some regional thoughts as well that go out beyond the walls of our healthcare centers, because I think that's important as well. So just to think about surges for a moment, I'm like to think of the thing simply, and surges to me mean more patients, much more than we are used to getting collectively, and I think most significantly for neonatology, non-traditional repurposed settings for those patients. So I think you all appreciate that pediatric patients, and probably even neonatal patients, although there's some conflicting data, our patients are less impacted by COVID. However, as neonatologists, moms are definitely impacted. And can get really sick. And of course, there's the issue of resources and personnel that I want to get into as well. So if I can move to the next side of the slide, I'm going to focus on how neonatology is affected in the next few minutes, and talk about PPE, equipment, and what I'm calling attractive real estate, and redeployment of hospital personnel. And I'm not going to go into detail about the issue of our personnel in general, except to point out that in some parts of the country, neonatologists have been redeployed to serve as adult intensivists. I know this is happening in New York City and maybe happening in other parts of the country as well. And that's something that we've thought a bit about here as well. Next slide. So just a few brief comments on PPE conservation. Early on, one of our big concerns at an institutional level were burn rates for PPE. If we don't have PPE, we are in a terrible place. And those of you who have seen reports from the East Coast, Connecticut, New York, appreciate in a very unfortunate way what's been happening at some of those centers. So one of the things that already happened in this region, I'll mention it again later on, is that there was one low volume delivery service in the region that made the decision very early to close in order to A, reassign their patient care staff if necessary, and B, reduce overall use of PPE in that center. And the other centers in our region have also been asked to conserve PPE by minimizing or reducing the number of people who interact with a patient and so on, so that PPE is available not just for maternity services and neonatal services, but also just for general hospital use and COVID management. Next slide. So equipment has been a bit more of an issue. And one that's impacted us as well, because neonatal intensive care units and level 2 special care nurseries have equipment that is of interest to other intensivists who may need to care for very sick COVID patients, in particular ventilators and also anesthesia machines. So in Ohio, all level 2 nurseries are required to have mechanical ventilators for neonates on hand, even if they don't routinely do invasive positive pressure ventilation in order as a contingency. And that equipment can, in many cases, be recalibrated for use with adult patients. And that's indeed what's happening in our region. Many of our level 2 special care nurses have been asked to share or repurpose their ventilators for use by adult patients. So when we think about something that seems relatively modest like this, we always like to think about trickle-down effects. And here, they're fairly minimal. If a special care nursery, level 2 nursery, doesn't have a ventilator, there might be a lower threshold to transfer to a higher level of neonatal care and put more pressure, if you will, on the level 3 and level 4 units in the region. And that might impact our bed capacity. But we've done the modeling here, and we believe that that impact is actually quite modest. Next slide. The attractive real estate issue becomes much more of an issue. So when I talk about attractive real estate, what I'm really talking about is the fact that level 2, level 3, level 4 neonatal intensive care units can, in many cases, be attractive places to care for adults who need intensive care services. They have the right head walls, or at least a pretty good head wall, and they have personnel who at least have critical care experience, as well as some extant infrastructure, equipment, and supply capabilities. So we can move to the next side of the slide. This leads, if a hospital leader has identified a level 2 or level 3 space for this purpose, that leads to some very important consequences. And I'm sharing with you on the right-hand side of this slide some of the issues that we've had to think about when this has come up in our region. First, how do you staff a transition if you're going to empty out one of these nurseries of existing patients? How is it staffed during that time? And how much lead time is necessary? The time from decision to, not incision in this case, but decision to implementation and being able to hospitalize adults. Another really important issue, and one that actually wasn't considered up front initially, had to do with the impact on the local labor and delivery services. For example, what's going on with a level 3 service that's taking care of high-risk pregnancies and that now has to transition to a level 1 service. How do you move the patients? What's the capacity of the transport system? And thinking about the fact that it takes about an hour and a half per patient to move from one site to another. And that, if you have 20 or 25 patients you have to move, that's better part of 2 full days. Next slide. So the attractive real estate issue also has impact on how you create a new nursery in a new setting. Here in Cincinnati, the Children's Hospital has space and was identified as the place where patients could be moved to. But that sets up a whole set of issues that you can see there around how to staff it, how to create the space, supply it, how to communicate with families as well as everybody else. Next slide of this slide. So what's happened in Cincinnati is that one labor and delivery service, that low volume service, was closed. Ventilators and anesthesia machines have been repurposed. One level 2 location has been transitioned to a new location within that center. And that's worked out reasonably well and hasn't impacted us. And in terms of nursery closings, we've had 2 false starts that we've had to prepare for and then backtrack. And that is no one's fault. That just reflects the fluid circumstances of the COVID epidemic. Next slide. So just to summarize this piece of it, equipment, people, places, collateral impact or trickle-down effects are really important. And then those interinstitutional interactions and surge planning and modeling that impact it all have to be considered from a neonatology standpoint. One more slide. I just wanted to take a minute to talk about what's going on outside of the hospital as well. I think most of you have heard that there appears to be a disproportionate impact on Black and Latino communities nationwide. And some very preliminary data that Ryan Everett was kind enough to share with me suggests that this is the case in Ohio as well. We don't know exactly why this is happening, but certainly some very obvious drivers have to do with health inequities and disparities that are already in place and get exacerbated when a pandemic like this is occurring. Some specific issues like masks that some people of color may not be comfortable using because of the insinuation that masks bring with them may also be problematic. And hospital visitation policies, which appropriately have been restricted, have to be restricted, have triggered some unintended consequences, such as an uptick, a substantial uptick of interest in home deliveries, at least in our region. And the link that I have on this slide is to a public service announcement that I, on the spur of the moment, basically taped at the end of last week, that was posted on our Cradle Cincinnati Facebook site initially, about home deliveries and giving some guidance about why hospital-based delivery was still the right approach and the safest approach for moms and for babies, even in the context of the COVID epidemic. So I don't want to take up any more time with this. I've run out of time, but I appreciate the opportunity to share my thoughts with you and be happy to answer any questions.
Thank you, Dr. Greenberg. That was very helpful. That was wonderful. We're getting a number of comments and questions, thoughts in the chat box specific to the restriction of visitation and the separation of mom and baby and the ramifications of that. I know that we spoke about that last week on our webinar as well. Any thoughts on that as we move forward?
Yeah, I wish I had a magic wand. We've been working regionally here with all of our maternity center partners around the issue of separation. And, you know, in general, these are case-by-case circumstances dependent and decision-making that's shared between the obstetrical team and the neonatal team based on mother's status and the status of other household members. With the principle that we'd like to minimize separation as much as possible. If a baby is born to a COVID positive mom, we are separating that baby immediately until we can complete neonatal testing, and we're now able to do that neonatal testing in Cincinnati. So it's an evolving situation. We fully recognize the challenges associated with separation and visitors restriction. It gets back to flattening the curve and kind of the temporary pain that we all are going through right now, including our families, in order to achieve that. But hopefully we'll get better as the days progress.
Thank you so much. And I think that what your words regarding shared decision making are really important and helpful during this time. There are, like I said, a number of questions and comments in the chat box. If you're able to respond to any of them, that would be wonderful. Sure. And I will go ahead and go to the next slide and introduce Kay Smith. It's my pleasure to introduce Kay. She is a practicing midwife at ProMedica Toledo, and she's also the Vice President of Operations for Women and Pediatrics for the system. You can see here they have a number, it's quite a large system, a number of hospitals in the northwest area of the state. She's going to share the surge planning for ProMedica's system. So we've heard from the state perspective with the data and surge planning from Ryan Everett. We've heard from Dr. Greenberg on a regional perinatal approach in the southwest part of the state. And Kay is going to share with us the system-wide approach at ProMedica Toledo. So Kay, I'll turn it over to you.
Great, thank you so much. Can you hear me okay?
I can, thank you.
Okay, good. So just a very brief listing of our system facilities. You can go ahead to my first slide, that would be okay. We actually at ProMedica, our system emergency management team made the decision to make a hospital in the system a destination hospital for COVID. So that decision was made, and then at that point, things kind of got down to the operational teams about how we were going to implement this and what the effects that would have. And I think a lot of it had to do with trying to maintain as many of our other units and hospitals with limited beds to be able to maintain what care they needed to do. Again, we also obviously stopped doing elective surgeries and those kind of things across the system in all of our facilities. But so we looked at centralizing. We looked for the favorable infrastructures in our facilities. We have some older facilities. We have some facilities that are just under construction. And then we have some newer facilities. I talked about the normal function. We also had a lot of, public concerns about where were the patients going to go. And I don't think it really played into the final decision of this, but it came out to be a good thing as we moved along. And also talked about limiting and managing the exposures that we had for healthcare providers, as well as other patients in and out of facilities. So we chose one of our metro community hospitals, which was a newer structure, to do all COVID admissions to as that destination location, which of course included obstetrics as well at that point. So this hospital did have a LDRP unit doing about 500, 600 deliveries a year. So they designated that, and in 72 hours, the practice that we have here at Bay Park for our Women's Services group had the honor of moving 365 patients out of our office to various locations in the community where we could share offices with other practices for those patients that would still have to be seen. We discharged our current patients in the hospital over about a 48-hour period to shut that unit down and open it for any obstetrical patients that would need to be admitted here. What I want to backtrack and say is each facility in the ProMedica system still does have the opportunity to have a patient who would present there, whether they're an adult or otherwise obstetrical patient, be processed for a patient under investigation or a positive to deliver, or be admitted there for medical management. So we didn't just say you can't go anyplace but here, but we do have those in the locations, as well as 10.9 miles down the road, our tertiary care center, Toledo Hospital, has set up several LDRs and ORs so that they could manage some of the higher risk patients that might be at a really less gestation from the very onset that we would know would need a delivery. So we still have an infrastructure throughout the system, but as the first 2 or 3 patients came here in the adult setting, we kind of cleared the rest of the hospital out and set up. So the hospital has been full with patients coming and going, and we've had some great successes in our adult population. Fortunately, I say we've only had less than a handful of obstetrical patients that have had to actually come through the doors for either suspected or positive disease. So it's been kind of a really neat opportunity to have a multidisciplinary team of intensivists, hospitalists, pulmonology, infectious disease, and our obstetrical team that we've designated to only be here, work together not only on our obstetrical patients, of course, but of all of the adult patients that we've had in the institution as well. So it allows us some good access. It keeps things all confined, and I think it's been a very, very positive thing for the community and for all the other hospitals to be able to maintain a lot of their other functions. Our next slide, just briefly, how we set this up to communicate then is if we had suspected patients needing admission, not only from our own facilities, but for transports to our normal tertiary care center, we go through what we call access, which is the bottom big long banner on this slide. And to set that up, we talked about how would we disseminate our patients, and this is kind of the demonstration of very quickly how our emergent infectious disease document for what we would do with laboring or non-laboring pregnant patients would do. So most of these bring you to what we call Bay Park Hospital or BPH. And again, we left out a little bit of stuff to go to Toledo Hospital if we felt that they were laboring, needed imminent delivery, and we knew that they were going to be of a smaller gestational age. We go through access. They call the maternal fetal medicine. He brings in the infectious disease hospitalists to make the decision of, one, does the patient really even need admitted? And if two, then what are the processes for that to occur? So just simple little algorithm for where that is. Next slide, just briefly. Our team in obstetrics includes our Director of Quality and Safety, which is Dr. Harper, our safety nurse coordinator, and then OB nurse managers from all of the nursing units come together and kind of work through these things. And we talk actually every other day during this to make sure that if there's issues and things that come up for the obstetrical world, that we can push documents out to all of our system providers or providers that have privileges within our system hospitals. So we did simulations in preparing for this at every facility, so that if a patient arrived at any of the facilities, how would they be managed, how would they be delivered, and how would that work? Dr. Harper and his team did that, and it was, I think, very successful to point out things that we could quickly make amends to make sure that we were safe and keeping our patients safe. We did convert the hospital at Bay Park could completely be converted to all negative pressure rooms, both adult and through obstetrics. So we have 12 negative pressure LDRPs and an OR in that obstetrical unit. We talked about screening patients before they come with admissions for scheduled admissions. We stopped using nitrous and supplemental oxygen during this time, as it was recommended with aerosolization that, you know, all of us could be assumed to have been positive and asymptomatic. We threw in our little use of the DeRosa shield, and the people at Toledo will laugh because we had a physician who was really worried about PPE when we weren't sure we had enough. So he used the drape cover, and that's what you see in the right-hand picture. The drape for over the table he hung on his poles to make sure that if we didn't have the right PPE, we'd have an option to help with delivery situations. We didn't do any elective surgeries. Of course, we were encouraging patients to go home maybe to 1 or 2 days. And then we've also moved now to having enough N95s and eye protection for all of our people. So that's kind of it in a summary. It's been extremely successful. We've had huge community support for the hospital that was designated with food being donated until I don't think they can eat it all. Drive-bys with police leading them I think the other night they had 76 cars that drove by and beeped their horns and waved at all the staff and stuff in the thing. So it's turned out to not only be a good thing for our system, but for the community, I believe. Thank you.
Okay, thank you so much. That was very helpful and heartwarming to hear of the positive feedback to the staff on the front line as well. You did mention briefly the early discharge for postpartum patients, and we have had some questions both on registration and in the chat box pertinent to that. And again, for those of you on the call, feel free to continue to utilize that chat box for our presenters. Can you say a few things about your discharge planning process? How has that worked with the early discharge you're attempting with the postpartum patients and the follow-up for that? Do you have a process in place? Are you still working through it? What's working there?
So clearly our early discharge was meant for patients in other facilities that were non-COVID patients, just to keep the volumes down and decrease their exposure throughout the healthcare system. Our discharge plan for patients we've had here, we just have been utilizing our transport coordinator to follow back up with those patients because they didn't come from our system, the people we've had in previous. So we sent them back into their communities as we would any other transport, and rehook them up with the providers in which were in their community for ongoing follow-up. For our patients that are suspected or homebound, we're encouraging and trying to monitor, which we don't even know if we can really get our arms around that yet, to be honest with you, without having universal testing, but to try to call those patients on a daily basis who are home and undelivered to be sure we can keep their status in the forefront and find out where they are.
Wonderful. Thank you. Thank you so much. I will go ahead and have you answer some of the questions that are popping up in the chat box there. And what I'd like to do now, as I mentioned earlier, we have participants from across the country on this call, from Connecticut to California and several states in between. We'd like to hear what other states who are further along with surge and peak have learned. We're all aware how very hard New York City has been impacted by the COVID virus. Dr. Dina Goffman is the Chief of Obstetrics at Sloan Hospital for Women at New York Presbyterian Hospital and Columbia University Medical Center. Dr. Goffman is on this call. I'm hopeful that you can share some feedback of what you've learned and what might be helpful to providers who are currently planning for surge here in Ohio and across the nation.
Excellent. Can you hear me?
I can. Thank you, Dr. Goffman.
So thanks so much for inviting me, and thanks for a really outstanding summary of where you guys are at. I think it's amazing to see how you guys are getting out in front of this and how much progress has been made already. As I listen to the other providers, presenters, sort of trying to think where to begin. Obviously, many of you have seen us in the news and are following the situation in New York State, certainly New York City, and our institution. We're right in one of the hotspot epicenter areas in Upper Manhattan, right adjacent to the Bronx. So we really are in the thick of it. And I think as I listen to others, things that I would just echo that we've learned, and I'm happy to take questions on any of the many important parts of this that came up, is I think some of the things that we did early that I would hope that others are thinking about is, I think the first thing is really over communicating. I think we realized early on, as we were encountering everything that's going on here, is the need to really be in very close touch with various multidisciplinary team members, and then to be able to share that communication broadly out to your staff, your departments, your hospital teams. And so I think very quickly we were recognizing the need to put infrastructure in place to have these kind of frequent touch points, frequent updates, and multimodal. You know, some people do really well with email, other people do much better with Zoom, and we're sort of learning as we go that over communication really is key. We also learned early on, as we were sort of limiting the number of in-person visits and needing to do that very quickly, we really ramped up telehealth at a rate that I never would have anticipated being possible. And so I would also encourage, it sounds like a lot of people are already doing this as well, to sort of think through visits and think through who needs to come in. The ability to social distance in the offices becomes much easier if you're doing much more of this through telehealth. So I've been sort of impressed with how that is working. I think another thing that was mentioned by one of the earlier speakers, this idea of redeployment. I've been thinking early on about the types of people and where they're best potentially able to help the team. I think in OBGYN, we're in a unique position because obstetrics, as everyone on this call well knows, is not something that's going to be able to be stopped or halted, and nothing that we really do is elective per se. So the fact that we needed to be able to maintain safe, consistent 24/7 coverage with a pretty deep backup plan as providers and nurses start to become sick and unable to come in was something that we really needed to think through and jump on very early. I think we also recognize that we have a group of gynecologists, most of whom are, board certified OBGYNs, and that one of the places that we could use some of their help may be in doing some things in the obstetric world that they wouldn't normally do, given the fact that the elective surgeries were really down. On the inpatient service, some of the things that we did early on that I think were really important, we're sort of thinking through our rounding processes and how to minimize people in rooms, even for patients who were not documented to be COVID positive, and sort of minimizing exposure, both with us, with each other, us with patients, and patients with us. So I think thinking critically through who your teams are, how you round on patients, to minimize exposure. I think one of the things this also helps with is your ability to optimize PPE and supplies. And so I think a thoughtful approach to that is really, really important. One of the other things in that arena that we were able to ramp up relatively quickly were more devices for virtual communication. So we're using a lot of iPads on stands in rooms with cleaning processes around those to be able to continue to interact with our patients even when we don't need to go in and out of the room quite as many times. As you would imagine, social distancing we've talked a lot about, but on an inpatient OB service, it's hard to always think through how to social distance for our patients as well as among our teams. Like, we're used to having these rooms where we come together and do sign outs and those sorts of things. So I think thinking creatively about how to create social distancing opportunities for your teams is also really important. We did a lot of schedule modifications, sort of putting residents and faculty into different pods and sort of who covered when, so a lot of schedule changes. I think people recognize that we had a lot of visitor policy concerns that certainly were public and in the news, but I think some visitor policy changes were an important part for us with the number of cases we were seeing and family members or support people who were symptomatic or becoming symptomatic during the patient's hospital stay. So I would just encourage you to think thoughtfully about visitor policies and what makes sense for you, and also how you're able to screen your support people with as robust a process as you're able to use. I know one of the other speakers really talked about postpartum discharges, and I think for us it's been a really interesting opportunity to think about enhanced recovery. I know we usually think about enhanced recovery after cesarean, but very quickly we started to see both patients and providers wanting to go home much sooner than they typically would. And so we're doing many, many postpartum day 1 discharges and post-op day 2 discharges for our cesareans with close follow-up plans in place. And then finally, I heard a lot of discussion about modifications of hospitals and OB services. We have closed one of our OB services within the last 24 hours, and so making plans to be able to make those units available to COVID positive adult patients who really did need hospital beds. But that's certainly a process in terms of figuring out how to incorporate additional volume, how to have additional space to make sure you can do it safely is something that I think may be worth thinking about before you actually have to do it. So I'll pause there and see if there are questions that I can help answer.
Dr. Goffman, thank you very much. There was a lot of back and forth in the chat box regarding universal testing of OB patients for COVID. Is this something you did at Columbia Presbyterian, or if so, what were the positives and negatives for, and not necessarily to the test result, but just
Sure.
the feedback there?
I can definitely speak to that. So again, I sort of have a role at Columbia as the chief of OB here, but I also do quality for the enterprise. We have 8 labor floors in our hospital system, and we went to universal testing for patients on admission to labor and delivery on March 22nd, and that was after we had a couple of index cases of women who were asymptomatic on admission and then deteriorated during the course of their labor floor stay and exposed just a huge number of staff members in various ways, and those women also got quite sick. So for us, that was the impetus to sort of think through what we were doing with testing, and so we did go to a universal swabbing approach on March 22nd. So we just finished, I think, our 3rd week of that. It's interesting. I think the data you'll see depends on where you're located. Even within New York City, there's just very different sort of prevalence of COVID disease in different parts of where we are. But we're certainly seeing some percentage of our COVID positive women are actually asymptomatic, and that percentage is very high. So if you look at all of our COVID positives, a huge number of them are asymptomatic when we swab them. And I think we don't know if they're asymptomatic and never will become symptomatic, or if they're just pre-symptomatic and we're catching them before the disease process begins to evolve. I would say we also are seeing of all deliveries, the percentage that swab positive but are asymptomatic at the time also varies across the campuses, but anywhere between 3% and 20%, depending on where you are within the city. And I think that has also changed over time as this pandemic is evolving week over week. So I think universal testing is, it's an option. I don't know that it's the right option everywhere, depending on where you are, what kind of access to testing, what kind of turnaround time, and what kind of prevalence you have for the disease.
Thank you. Thank you very much. We do have a couple of questions in the chat box. I'm hopeful you'll be able to answer as I'm going to move forward and wrap things up for the afternoon. So we can go to the next slide, please. We have, as Dr. Marcotte said, been doing these on a weekly basis. For those of you that tuned in on the very first webinar we did, we heard from an OBGYN in the Cincinnati area who had a patient in the ICU that was pregnant. And I understand that patient has since delivered, and we are going to go ahead and do a case study on that, including the use of and benefit of simulation and debriefing on next week's webinar. We hope you'll be able to join us for that. And then the next slide, please. Sincere appreciation to all of our presenters today, including Dr. Goffman, whose name is not up here. Very appreciative to Dr. Marcotte, to Ryan, to Dr. Greenberg, and Kay Smith. This slide deck will be posted on our webinar, and you'll have access to everyone's email should there be an interest in contacting any of our presenters. And if we go to the next slide, please. Again, the recording for this slide, or for this webinar, along with the slide deck, will be posted, as are the resources that were discussed today in the chat box and on this webinar. And we will go to the next slide. And again, just want to end with thanking you all for taking the time today to all teach, all learn. Hopeful that this has been beneficial to everyone. We do hope you take good care out there, and we'll talk again soon. Thank you and goodbye.